Sleep terrors are commonly seen in children aged 2 to 6 years, but they can be seen in older children also. They are recurrent episodes of abrupt awakening from sleep that usually occur during the first third of the night and often start with a scream. Individuals are usually responsive to the efforts of others to comfort them during the episode and do not recall the episode in the morning. Treatment is supportive, and most children outgrow these over time. Nightmare disorder is defined as repeated awakening from sleep with detailed recall of frightening dreams, usually involving a threat to one's safety. The awakenings generally occur during the second half of the night. On awakening, individuals become alert and oriented. New onset hypertension along with hypernatremia, hypokalemia, and metabolic alkalosis suggest a hypermineralocorticoid state. The next step in diagnosis is to check the levels of both renin and aldosterone to obtain the plasma aldosterone-plasma renin ratio. When the ratio is greater than 20 to 25, sensitivity reaches 95% and specificity 75% for primary hyperaldosteronism. Pulmonary contusions are a consequence of blunt chest trauma and usually develop over the first 24 hours after an injury. Radiograph findings consistent with the diagnosis include an irregular non-lobular opacification of the parenchyma. Admission for pain control and pulmonary toilet, as well as monitoring to prevent pneumonia and acute respiratory distress syndrome, is important for patients having trouble maintaining oxygen saturation. Lyme disease is characterized by a target rash, fever, and lymphadenopathy. Arthritis is a late manifestation. When erythema migrans is not visible in a patient who has suspected Lyme disease, diagnosis must be confirmed using ELISA, followed by Western blot. Treatment of Lyme in children younger than age 8 is amoxicillin. Treatment of individuals older than 8 is with doxycycline. Even though the incidence increases with maternal age, young mothers can also have children with Down syndrome. Classic features are hypotonia, upslanting palpebral fissures, low set ears, epicanthal folds, excess knuckle skin, and large tongue, clinodactyly of the fifth fingers, and a single transverse palmar crease. Patient has hemochromatosis, which can manifest as rheumatic complaints. The disease is due to iron overload and deposition in a variety of organs, including the liver, heart, and pancreas. Skin lesions, erectile dysfunction, diastolic and systolic dysfunction, fatigue, diabetes, and thyroid disease are common complications. Transferrin saturations levels are above 45%, suggesting the diagnosis. The next step is genetic testing for C282Y mutation. C282Y, which should be done in all individuals with abnormal iron studies and first-degree relatives of confirmed homozygotes. The primary treatment after confirmation of diagnosis is phlebotomy. It's preferred due to its ease and low cost. Each 500 ml of whole blood removed contains 200 to 250 milligrams of iron. The marrow, in providing replacement for the lost hemoglobin, mobilizes iron from tissue stores, thereby reducing the degree of iron overload. Many Hepatologists recommend weekly phlebotomy until the iron stores are normalized, defined as a serum ferritin concentration less than 15 nanograms per milliliter and transferrin saturation less than 45%. With early diagnoses, 30 phlebotomies or fewer may be sufficient. A maintenance phlebotomy schedule should be continued following primary iron depletion to prevent reaccumulation of iron. A reasonable goal is to keep the serum ferritin concentration at 50 or less. Most patients require a 500 milliliter phlebotomy for every 2 to 4 months. Acquired perforating dermatosis, Kyrie disease, is most often associated with chronic renal failure and diabetes mellitus. Clinically, the patients present with pruritus and excoriations or umbilicated papules with a central keratotic crust favoring their lower extremities. Acute papillary muscle rupture is an acute complication most commonly presenting 3 to 5 days after myocardial ischemia. Mortality rate is very high and emergent surgical intervention remains a treatment of choice. Presenting symptoms of papillary muscle rupture are pansystolic murmur, radiating to the axilla, sudden drop in BP, and acute heart failure. An intracranial aneurysm can compress the third cranial nerve, resulting in a third nerve palsy. Causes ptosis, a large unreactive pupil, and paralysis of adduction, elevation, and depression. Berry aneurysm is usually associated with polycystic kidney disease. Type 2 renal tubular acidosis is a non-ion gap metabolic acidosis and hypophosphatemia. Osteomalacia is a defect in bone mineralization that can be caused by persistent acidosis or defects in osteoid formation. Signs and symptoms of osteomalacia include bone pain, pathologic fractures, serum chemistry abnormalities, especially with phosphate and calcium. Type 2 Type 2 RTA can cause osteomalacia because of proximal phosphate wasting, calcium loss because of acidosis, and potential secondary hyperparathyroidism. Fetal valproate syndrome, craniofacial anomalies, narrow bifrontal diameter, high forehead, epicanthal folds, broad and low nasal bridge, midfacial hypoplasia, long philtrum, and small mouth. Increased risk for cardiovascular anomalies, increased risk for cleft lip and meningomyelocele, and about 30% of exposed infants have these features. A cavitary lesion in the upper pulmonary lobe is suggestive finding for reactivational or secondary TB. Common symptoms of TB: subacute fever, chills, cough, weight loss. INH, rifampin, pyrazinamide, ethambutol are used to treat secondary pulmonary TB. Uterine hyperstimulation is a consequence of oxytocin overdose. First step in management is to discontinue. Tocolysis should be reserved for the cases that do not respond to conservative measures. Oxytocin is one of the most frequently used medications in the U.S., very effective at producing contractions, and used very often for induction of labor. The most common adverse effect is a non-reassuring fetal heart rate pattern brought about by uterine hyperstimulation, because it has a very short half-life, 3 to 5 minutes. Discontinuing the oxytocin often resolves the hyperstimulation quickly. Patient with fetal bradycardia to the 80s. This step is most appropriate in the situations where the fetal heart tracing is not as reassuring. Oxytocin dosage may be reduced rather than discontinued completely. Prostaglandin E2 gel is another widely used uterine stimulant for labor induction. In simple terms, it is used to soften an unfavorable cervix. To make the cervix more favorable for induction, it has been shown to lead to an improvement in the Bishop score, a shorter duration of labor, a need for lower maximal doses of oxytocin, and a reduced incidence of cesarean deliveries. PGE2 gel can also cause uterine contractions and uterine hyperstimulation, also one of the side effects. IgA type heavy chain disease is seen in people of Middle Eastern descent, ages 10 to 30. Most common presentation is an abdominal mass and malabsorption syndrome. Lesion is usually confined to the gut and mesenteric lymph nodes and behaves like an abdominal lymphoma. Cells may or may not be obviously malignant. Serum protein electrophoresis typically shows either a decreased gamma fraction or a broad band in the alpha 2 and beta regions. Never use epinephrine on the digits, penis, or cartilaginous areas, ear and nose, because of the risk for vasoconstriction and infarction.